All right, so my name is Maroun Mhanna. For the one who do not know me yet, I'm the relatively new. I'm the incoming chair of the Department of Pediatrics. I'm a pediatric critical care specialist and a neonatologist, and I have the pleasure today to introduce my colleagues, Dr. John Vanchiere, who's the professor and chief of pediatric infectious disease here at LSU Health in Shreveport, and he's also the director of the community testing and vaccine, and Dr. Sami Bahna, who's the professor and chief of allergy and immunology also. And we're here today to address some of the confusion, the concerns, and questions regarding COVID-19 infection and the available vaccines to us. I'm going to start by shedding a light on some staggering numbers that are of a great concern. Worldwide, COVID-19 pandemic has affected 103 million plus people, and with a death rate of 2.2 million. I have this graph on the right-hand side here to show the rate of death amongst people who are infected with the virus. And Mexico, as you can see, is on the top of the list. In the United States, is way down here. But still, in the United States, we're around 1.7% rate of death. How about the United States? So far, these are 26 million plus confirmed cases. This is the data from Johns Hopkins that everybody's been tracking. And this is as recent as last night. The total number of deaths in the United States is 446,272. How about Louisiana? Our state we have 401,000 confirmed cases, almost 9,000 deaths. The vaccine's been given to 397,000 people. This is the data, again, from the website as of yesterday. And however, people who are fully vaccinated, and as you all know, to be fully vaccinated, you need 2 doses. They're only close to 58,000 people. So we're only 1.24% fully vaccinated as of the most recent data. I decided to pull a couple of surveys to shed the light on the reason why we're doing this presentation today. This is a study that was published in Nature Medicine in late October 2020. And that's a survey that was conducted back in June of 2020 across 19 different countries, and the respondents were close to 13,426 people. And as you can see, in the United States, we fall right in there as 75% of the respondents, or the ones who were surveyed, agreed that they will consider taking the vaccine. And remember, back then, there were no vaccines available yet. It was still under study. And as you can see, there's a difference in acceptance to take the vaccine between the different countries. As you can see, Russia is the lowest, and China is the highest. When we look at the survey among U.S. citizens and adults in the United States, and that's another study published in the Annals of Internal Medicine, again, another respectable journal, in December 15th of 2020, it shed some lights on the reason and the factors is associated with hesitancy or second guess for why wouldn't they take the vaccine. And what was really striking, that out of the 991 participants, the factors that were seen associated with hesitancy are a younger age, black race, lower educational attainment, and not having received the influenza vaccine in the prior year. And other reasons for hesitancy being the vaccine-specific concerns, a need for more information, anti-vaccines attitudes and beliefs, and of course, a lack of trust. So what about us as healthcare professionals, which means not only physicians, but physicians, nurses, allied health professionals, people who work with patients, not necessarily physicians. This is a study that made the news, and it was out of sunny upstate New York from Syracuse, showing that the third of nurses and a third of allied health professionals and a third of master's level clinicians these are not physicians, but folks who work with patients, they were kind of hesitant to take the vaccine. They have concerns. So there's a lot of concerns, a lot of myth, a lot of confusions about the vaccine and what happens if we take the vaccine or we don't. And I'm going to ask my colleagues to, to talk about, the infection rate in this country, how we're getting infected, what is the transmission rate, and a little bit more about the vaccine and its benefits and safety. Here I'm going to ask Dr. John Vanchiere to take the podium and talk about the diagnosis and effective treatment protocols for COVID-19.
Great, thank you, Dr. Mhanna. So this graphic shows what we have learned in a compiled vignette over the past year now about the pathogenesis of COVID-19 and sort of how it causes disease. And what's important actually is what's not shown here, because this graph begins at the far left looking at time after infection, and it tracks from left to right the time course. And so we know that early on, when people get infected with the COVID-19, the SARS-CoV coronavirus, most people have no symptoms at all. And that is one of the very critical features of this type of infection compared to influenza. It is that many, many more people have no symptoms at all. And we've also learned that those who are going to develop symptoms, that is in the pre-symptomatic phase, before they have symptoms, they have very, very high virus levels in their nose. And so that is the time period when transmission is most likely to occur. It's before you know you actually have infection with the virus. It's before you're diagnosed, it's before you have any symptoms. And then the cascade of things that happens after that, for the vast majority of people, they stay with no symptoms or very mild symptoms. And those who progress to more severe disease, a pulmonary phase, and a hyperinflammation phase, those are patients who are going to the emergency room and to the hospital. But again, for the vast majority of people who get infected with this virus, it is a relatively mild course. What is also shown on this graph or slide down at the bottom is what are listed as potential therapies. And you've heard about these in the news for many months now: remdesivir, chloroquine, hydroxychloroquine, convalescent plasma, and now we have monoclonal antibody therapies that are becoming available. But one of the most concerning pieces is that we don't have any sort of home runs in the therapeutic category. We have a few treatments that have modest effect at best. And so the next slide is really the list of really what scares me as an infectious disease doctor about COVID-19. And the first of this is, as I mentioned before, asymptomatic spread, or people who have no symptoms spreading the virus, is extremely common. We've seen this in nursing homes, we've seen this in prisons, we've seen this in the community. And that potential for spread is greatest before folks have any symptoms. Number two, virus levels in the nose are highest before symptoms. We've seen this again in all of those environments. Number three, the unpredictable outcome at all ages. And my teams have been working in the nursing homes in our area for the past almost a year now, and we've seen individuals who are 104 years old get COVID-19 and do just fine, have very mild symptoms, never have to go to the hospital, never require extra oxygen. But we've also seen teenagers and young adults who've never been sick a day in their life and have no other chronic illnesses succumb to this virus in very difficult ways, with long hospital stays and intubation and long ICU stays. And what we can't explain now is that unpredictability. That why is it that some young healthy people seem to be very susceptible to developing critical and fatal illness from this virus, and others who are older, which is the number one risk category for bad outcomes is older age, have very good outcomes. That unpredictability scares me. Finally, the lack of medications to treat early infection. Our focus has been on medications for those who are hospitalized, because they're the ones more likely to die, and we understand that now. but we really haven't found a group or even one really medicine that changes that outcome once people go to the hospital in substantial ways. We're using great therapies. We have changed mortality. We have saved a lot of lives by doing things differently, but we really haven't gotten to the point yet where we have medications that we can use early on in infection to prevent the progression to severe and critical disease. And that's a real shortcoming in what we have in our toolbox at this present time. Because if we can treat early infection or even prevent infection in the first place, again, by vaccines being the best way to do that, then we can do even better at saving lives and keeping people from ending up in the hospital very sick. And last, as I mentioned before, sort of the futility of many meds for late infection. We are trying things like remdesivir and other hydroxychloroquine like in the hospitalized setting, and they have a modest effect, but they're not really big game changers like what we need. We need better medications. So I get many times the question about why are we right now limiting vaccinations to people over age 70? And in different states, it's over age 65 or 70. Each state gets to make their own guidelines there. And there are two major factors that are important to know. One is that the vaccine supply right now is not very robust. We have a limited supply of vaccine. And I understand that everyone, many people, almost everyone would like to have vaccine, especially our older adults. This graph shows the second major point there, and that is the death rate by age per 100,000 population across the entire United States, and this is the period of January 1st last year to January 23rd this year, okay? So let's start with, if we just take all Americans on the far left, the death rate is about 110 per 100,000. So 1 out of 1,000 people who gets COVID dies of COVID in the grand big picture, okay? But when you break that down by age range, what you can see is that for those less than a year of age, we're talking about 1 death per 100,000. When you get to the school age children, or preschool and school age, 1 year up to 14 years of age, 1 out of 1 million infections results in death. So it's a very low rate, and that rate begins to climb as you get into young adulthood. 5 per 100,000 in the 20s and 30s, triples to 15 per 100,000 in the 35 to 44-year-old age range, and you can see it goes up. And it meets that 100 per 100,000, or 1 out of 1,000, when you get to age 55 to 64, and a dramatic increase after that. And in the 75 and older age group, 622 people per 100,000 die of COVID, and in the over 85 age group, 1,750. That's about 1 out of 6 people in our country over age 85 has died of COVID. 1 out of 6, okay? And so you have to look at these numbers based on the population. And I've said before, I don't envy the decisions that have to be made by our governor and by others about how to distribute vaccine, because it is very complex. There are many factors, and there are many hundreds of thousands of people who are anxious to get the vaccine as quickly as possible. But it's the numbers like this that remind us where the greatest risk of death is, and it is in our older population, our older age population. So with that, I'll just address a couple of things. One is that we have learned very well that transmission of this virus is mostly by respiratory droplets. We think that there may be some of what we call aerosol transmission, which is the finer droplets that can linger for a long period of time in the air, but respiratory droplets are the biggest mode of transmission. And we talked early about, in the pandemic, about surfaces and contact with surfaces and touching things as a mode of transmission. Again, that can be a mode of transmission, but it is not the major mode of transmission. The major mode is those respiratory droplets that people are coughing out or exhaling that don't stay in the air very long. But when you're in close contact with other people, those are the major mode of transmission. Our diagnostic methods are very good now. And we have, in our area and across the United States, I think it's fair to say we have very, very good diagnostic methods. We are seeing that fewer people are going for testing. And I think that it's important to reinforce that testing is important. If you have symptoms, please get tested, because that's how we're able to identify where there's an outbreak, to track the different variants that may be coming into our area before too long, and to understand your contacts and who may also get infected from you. Because again, go back to the second slide there, it's that unpredictability of who will get very sick that is, to me, the most troubling part of this pandemic. So I want to encourage testing, especially as we vaccinate more, because we want to know as soon as we can if there will be strains that are not responsive to the vaccine, that the vaccine does not protect against. I've been asked many times about whether we're seeing variants of the UK variants, the South African variants, and at this point in our area, we have not seen those in our genetic analysis of COVID-19 strains from this region of the state. But we are very actively working to look for those among the samples that come into our laboratory here at the Center for Emerging Viral Threats. So with that, I'll stop and pass the baton over to back to Dr. Mhanna.
Next, I'm going to introduce Dr. Bahna to discuss the efficacy, safety, and benefits of the vaccine against the virus.
Thank you very much, Dr. Mhanna. My first slide is to complement what Dr. Vanchiere just mentioned about the infection. In this slide to your right, the pink cell is the human cell or our body. That is on its surface, there are certain receptors that are involved in the regulation of the blood pressure. On the left-hand side is the virus that is studied all over its surface with a spike protein. The virus attacks through these receptors, or we can say these are the windows where the virus can invade and replicate inside the human cell and cause harm. So this is a fight. And simply, if you look at this cartoon, you can predict in advance who is going to be the winner in this fight. A lot of windows on the human cell, a lot of spikes or daggers that can attack the cells. And this was predicted very early last year when the National Institutes of Health predicted 100 to 200,000 people to die within 1 year. We did not like that prediction. And we thought it is an exaggeration. But the fact was almost double that, 400,000 deaths in the first year of the vaccine. So it is a terrible fight. However, our body is equipped by natural immune response. So in this cartoon, simplified, the protective immune response, when the virus or particles of the virus, and equivalent as well as can be the vaccine, when that foreign part enters the body, a certain cell will engulf that particle and process it and deliver it in a certain way to another very important lymphocyte called the T cell. This cell is further dealing with that particle, produces certain mediators or chemicals and physical interaction with its sister lymphocyte, which is called the B lymphocyte. That B lymphocyte is the antibody-producing cell, and it will produce antibodies specific to that virus. A proportion of that B cell will maintain a memory about this process. With repeated exposure, whether through a booster dose or a virus, again, more antibodies will continue. Therefore, these antibodies in the circulation, as well as in the tissues, when they encounter the virus, the antibodies will stick, will bind to these daggers and render it ineffective. What do we expect from a good vaccine? Strong immunity plus high safety. And in fact, safety precedes the benefit. All the animal studies and the initial human trials is to prove safety first. Of any drug, any new thing developed in medicine, safety is of utmost importance. These two issues, strong immunity and a high safety, will depend on the vaccine's efficacy versus undesirable side effects. The attacking virus quantity and virulence, meaning even when having a very good vaccine with very low side effects, I still not to expose myself to the danger. It is good to have a very good car, but I have to drive it carefully and keep distance from the other cars around me. The third factor is the body's health, the status of the immune system, as well as the comorbid conditions if I have diabetes or hypertension or liver disease and the other things that can make my body weak. There are a lot of vaccines developed, fortunately, because of the tragedy of the pandemic. The manufacturers, the scientists, and by the way, I acknowledge the great work that's done in our institution by very good virologists and immunologists. We are at the cutting edge in the laboratory side. So far, more than 10 available vaccines in the world, more than 50 in the pipeline close to come out after it become registered and approved. Close to 200 in the preclinical stage. This is a big war. Scientists, governments are fighting in every way. And every one of us is in this fight by whatever we can. So these vaccines can be manufactured in 5 different ways, either inactivated killed vaccines like many vaccines already for other diseases, or certain recombinant part of the protein of the virus, or putting the part of the spike that's not infectious inside a very innocent vector or a carrier, like the chimpanzee adenovirus, or making encoding or copying the spike protein and using a vaccine from it, and the RNA vaccines that we have at the current time in the United States, 2 of them, and this is synthetic messenger RNA. To ensure vaccine safety, which I emphasize is of utmost importance, extensive animal studies are done first to know that it is not harmful toxicologically to the animals. Then, phase 1 in the humans to look for safety in a small number of healthy volunteers. And this thanks to these volunteers that they accepted that. Without them, we would not proceed to a safe medicine or a vaccine. After that, we'll go to the clinical trials in a large number, minimum 30,000, and all the vaccines that are being done now, particularly the messenger RNA, done in more than 40,000 initial human trials. Then the data is reviewed by an independent group of experts, have nothing to do with the manufacturer. Manufacturer's regulation throughout, from the beginning to the end, They're under heavy regulations and monitoring for the accuracy and sterility. Rigorous testing is conducted at each step. The currently available in the United States, as of now, is the Pfizer mRNA, which requires deep or ultra cold freezers. It is indicated for the 16 years and up, and to be repeated after 3 weeks. The efficacy is very high, unprecedented efficacy in any vaccine. The Moderna, also a messenger RNA, it requires freezing at the regular freezing that you have at home. It is for 18 years and up, repeated after 4 weeks. The efficacy is also very high. They expected very soon, hopefully this month, the Johnson & Johnson, the vector adenovirus vaccine. And this can be kept at a regular refrigerator. And for 18 years and up, the efficacy in general, or for the mild, moderate, and so somewhat severe, is generally 66%. But at 85% preventing severe disease, and what we wanted to avoid hospitalization, intensive care unit, and death. By the way, somebody will ask always which one is the best. These vaccines have produced at different times in different populations, different circumstances, and not yet have head-on comparisons. The side effects, undesirable effects of the vaccine, some of them are good. Actually, we wanted them to happen. If they don't happen, that's fine. But when it happens, this means the administered vaccine is started to interact with the immune system. And this is with almost any vaccine. So locally at the site of the injection, there will be some pain, redness, or slight swelling. Or in general, there is fatigue, headache, joint pains, and some patients have fever as well. These last for 1 day, maximally 2 days. The person may take a simple symptomatic medications for them. Rare allergic reactions, either immediate urticaria that are familiar, swelling, wheezing, very rare anaphylaxis. The reported figures are 2.5 to 11 per million doses. The late reactions are very rare. Serum-like sickness. A month ago, I was consulted in one case was in another state, and the patient recovered very well. She was a physician, and she did very well. By looking at these figures of anaphylaxis, that's frightening people. If we vaccinate every person in our city who is 16 years and up, we expect as 1 case of anaphylaxis. I will just address one study about the anaphylaxis that showed the high figure, which we think maybe the diagnosis may not be accurate in every one of them either. But let us assume that the 11 per million dose is correct. The analysis of this data, 4 out of the 21 were hospitalized. 80% of the 21 was treated in the emergency department and went home. Always we advise that a person with anaphylaxis, even if it is mild or started treatment, will still go to the emergency department. Many of them will arrive to the emergency department and they improve. The onset was after a median of 13 minutes, so it's an immediate. 70% of them within 15 minutes, which is the recommended interval to wait in most patients. A few more needed to stay longer because the anaphylaxis started 30 minutes. And only 3 were after 30 minutes. 80% had past history of allergies. So genetically, they are predisposed to allergies of any kind, medication, food, and things. And 1/3 had past anaphylaxis. Again, there is genetic predisposition to certain people, the minority. One of them to a vaccine of rabies and one to vaccine of the influenza. Fortunately, I'd like to emphasize this, although anaphylaxis is a major problem and can be fatal, none of these patients died. It's worth noting to see that some patients will not be advised to get the vaccine. Those who got a systemic allergic reaction, either anaphylaxis or a generalized reaction to the first dose of the vaccine or to a similar vaccine to the COVID. Another group, allergy to an added ingredient to the vaccine, which in the messenger RNA is polyethylene glycol, certain type. There are several types of them. Or its similar substance called polysorbate. Both these materials are very widely used in stabilizing a lot of medications of any form. And this is a very, very rare condition. And I added recurrent anaphylaxis of unknown cause. There is a category of idiopathic anaphylaxis. These unfortunate individuals, they go from one medical center to the other, and they receive very detailed evaluation, and we cannot find it. So if by chance they will get one of these episodes after the vaccine, of course they are going to think or accuse the vaccine. Precautions. Proceed with caution if the patient had systemic reaction to another injectable vaccine. This is not a contraindication, but to be extra cautious. So we keep the interval 30 minutes instead of 15. Postpone vaccination in the presence of any acute infection, including symptomatic COVID-19. No need to make the immune system fight 2 wars at the same time. The last slide is controlling the pandemic. We need the vaccination, not just in numbers, but also in speed, to build the so-called innate immunity and reduce the chance for the virus to change its characters, to mutate and give us a new variant. In addition to the vaccination, avoid exposure by every way as usual. And influenza is a bad disease also, so it's good to get the vaccine so that the person does not fight both. I was very pleased to get the vaccine right away when it became available. And please let us make the year 2021 is the year of healthier choice. Thank you.
Thank you, Dr. Bahna, for this beautiful presentation and thorough. The title of this presentation is pretty much to address the questions and that that physicians and healthcare professionals and even the public questions that they have regarding the safety of the vaccine. And we've received many questions for this webinar, And in order to address the majority of them, we lump them into categories or themes. I'm going to start with the first theme under fertility, pregnancy, and breastfeeding. And we've got several questions, or many questions actually, in addressing the same issue and asking the same, the same questions pretty much. The first question is effect of COVID-19 infection on pregnancy, and I'll ask Dr. Vanchiere to address this first question, please.
Sure. So the data that we have available now tells us that pregnant women who get COVID infection have no worse outcomes in terms of their own health than women who are non-pregnant. So pregnancy is not a condition that makes COVID worse. However, when you look at pregnancy, you also have to consider the baby. And we know that infections in mother can lead to complications for the infant. And so with COVID-19, like other things, like influenza and other virus infections that can occur in pregnancy, those can precipitate preterm labor because of mom's immune response during pregnancy. There are not severe consequences of infection for the baby per se. There are not genetic or not malformations or anomalies that occur because of the virus, like some of the other viruses we've dealt with in past decades. And so we do encourage mothers to be particularly attentive to the precautions of mask wearing, hand washing, et cetera. When it comes to the question of the vaccine during pregnancy, we have very little data, and most of the decisions that have to be made are really going to use a risk versus benefit analysis, and that will be an individual discussion between a pregnant mother and her physician. And that's because some pregnant women they may work in a healthcare setting, for instance, or in a nursing home where there is higher risk of exposure. And in that case, you may opt for vaccination, and for other pregnant women who are not employed in high-risk environments or exposed to high-risk settings on a regular basis, they may opt not to get the vaccine. So that's a discussion. The limited amount of data we have from the Pfizer and Moderna studies is just a few dozen patients who became pregnant shortly after they got their vaccination, and we saw no safety issues among those. But the real information, the data we really need will come in the next year when we begin studies of specifically the vaccine response in pregnant women, during pregnancy. And vaccinating pregnant women is one of the particular studies that is in preparation right now to begin probably this summer. So again, right now, the bottom line is we have very little data. We have no indication of problems during pregnancy related to the vaccine. We know that COVID can impact mothers and impact the health of their babies. So we opt for a cautious note there.
Well, thanks, Dr. Vanchiere. There's two other questions in the same, out of the same theme that you pretty much answered. If the pregnant mother can affect her newborn. As a neonatologist, I can tell you that we don't see that much of a transmission from the mom to the baby, and we encourage to keep the baby with the mother who is COVID-19 unless the baby has other symptoms or need of medical attention. And that's pretty much the recommendation from the CDC. Adding to that, I'm going to ask Dr. Bahna, the question is really related to the same topic of pregnancy and fertility. Should I delay pregnancy if I take the vaccine? And does the mRNA vaccine have the potential to affect fertility and my baby? So, if you don't mind, Dr. Bahna.
Okay. Pregnancy is a physiologic process, not a disease. And there will be no studies done intentionally on pregnant women, but we rely on the experiment of nature. Some women got the vaccine and they didn't know that they're already pregnant. And some, after they got the vaccine, they got pregnant. Those women were followed and they found the pregnancy went well, and the newborn went well, and the breastfeeding went well. In fact, the vaccine produced the antibody in the mother, the so-called IgG antibodies, which cross the placenta generously into the baby. So the baby comes down already protected with a good quantity. And the breast milk has such antibodies, although it is of limited value because the enzymes in the stomach will digest it quickly, but it is not harmful at least. So that is regarding fertility, pregnancy, and newborn. This is left to the experiment of nature, and more cases are being accumulated.
The question is about breastfeeding, and you just answered it, Dr. Bahna. Moving on to the other theme, because we don't want to just have the entire session on one theme, is actually questions regarding the transmission, the different type of vaccines that are available. First set of questions I'm going to ask Dr. Vanchiere to address. Does the virus come out in the saliva or sweat or in the urine or feces?
So we know that the virus can be detected in saliva, and whether that is a major mode of transmission is still a little uncertain. It's not very likely a mode of transmission, but if you drink after someone who has COVID, you possibly could acquire COVID infection from their saliva. The other body fluids, urine is not a major source of virus that allows it to be detected, and so it's not a route of transmission. Feces is one area where we can detect the virus, and others are using studies of actually sewage to know where virus is abundant in the population, because sewage is a reflection of a community level, not an individual level of virus and transmission. And so we are using sewage detection, as others are, to understand where the virus is in the community, especially where it is more prevalent in the community. But it is not considered a significant mode of transmission. And then the other one you had on your list was?
I would talk about saliva, sweat, urine, or
Yeah,
feces.
sweat is also not a mode of transmission that we need to be concerned about.
So there was another question within the same rubric is the new virus variant present in Shreveport or surrounding areas? And you've already addressed that question during your presentation.
Sure. I'll just add to that the state of Louisiana has reported detection of two of the variants of concern that reflect the UK variant, both in South Louisiana. I don't have any other further details about those, but we have not detected any of the UK or South African or Brazilian variants in the Northwest Louisiana region.
Thank you. I have a question regarding the vaccines to Dr. Bahna to address. Does the vaccine make the person positive for COVID? And can the person take the influenza vaccine and COVID vaccine close to each other?
The first question, no. The vaccine does not make the person positive. What the test is positive by the PCR for the virus itself. There is another test for immunity. That is not a diagnostic, that is confirming that the person got immune. Second part, the two vaccines, the influenza and the COVID, are important vaccines. But again, we don't want to put a burden on the immune system to produce two major things at the same time. So 2 weeks in between will be a very good idea.
Thank you. Actually, this question regarding the person can turn positive after COVID, it is funny when you read the papers online, and these are not scientific papers. These are, pretty much, internet based, news outlets. And there was a specific question asked, and I was reading this yesterday about, can we turn positive after getting COVID vaccine? And the answer was yes. But the answer was yes because it takes a week to 10 days for the vaccine to become efficient, and maybe somebody was already exposed beforehand, before they took their first shot, and then turned out to be positive during that period of awaiting for the vaccine to be effective. So there are a lot of misconception out there, and we have to be careful when we go online and ask Dr. Google some of these questions. We might get answers that may or may not be really accurate. And just go ahead.
Can I just magnify on that? So I think it's important to know which test you're talking about. So if we're talking about a nose swab looking for the virus, as Dr. Bahna said, that will not be positive because of the vaccine. However, a blood test to look for immunity should become positive because that's what we want to happen. So those two different types of testing are for different purposes. The transmissibility, though, and the infection with the virus is related to that nose or throat swab, depending on whichever you're getting.
Another set of questions that related to the same theme for you, Dr. Vanchiere. How long do I need to be quarantined after I test positive? And if I get COVID and recovered, do I need to be isolated until my test becomes negative?
So very important questions. We'll take the second one first, and that is, do we need to retest to be negative before we can stop quarantine? And the answer is no. Very early on, we learned by repeated testing, especially in nursing homes of people who were infected with COVID, that some people will continue to have a positive nose swab, PCR test, for even 6 or 8 weeks after their initial infection. And what we also know is when we look at the amount of virus that's being detected, it's very high before symptoms. It comes down as people have symptoms. But after 10 to 14 days, even if you detect virus, it's at very, very low levels. It's considered non-infectious levels. And that virus has already been subjected to your immune response. And as Dr. Bahna showed in his slides, that it may be coated with antibodies and other things from your immune response. So any detection after 14 days is considered non-infectious and not concerning. There's no reason to retest. Employers should not be requiring you to have a negative test to go back to work, same for school, etc. It's not a good use of resources also. So on the first question related to quarantine, and early on, we were very strict about a 14-day quarantine period. And that was because of mostly the lack of data about how long that virus is infectious from a person who's been infected with COVID. And in the past couple of months, CDC has relaxed those restrictions. And what they have said, and what others in public health have said, is that 14 days is still the gold standard. It is the best. However, if you reduce that quarantine period to 10 days, you're only incurring a little bit of extra additional risk by doing so. And so depending on your circumstances, a 10-day quarantine is not unreasonable. What that means is that the risk that you would transmit to somebody between day 10 and day 14 is around 1% or less. So it's a relatively low risk period. It's not zero, but it is a low risk period that is acceptable at a public health level. The other strategy is, if you've been exposed but not infected, how long should you quarantine? And again, the general recommendation now is 10 days of quarantine after exposure, as long as you don't have any symptoms that develop, fever, chills, respiratory symptoms, etc., loss of taste or smell. However, if testing is available, you've been exposed, you are allowed to test at 6, 7, 8 days after your exposure, after your last exposure to an infected person. And if that test is negative, then go back to work or school or whatever you need to do. So again, 14 days is the gold standard after exposure and after infection, but 10 days is acceptable after exposure and infection under the circumstances we talked about, and it may be less, 7 to 8 days, if you test negative after an exposure.
Well, thank you for the clarification. For Dr. Bahna, there was a series of questions related to the vaccine under this topic. Does the vaccine work against the new variants? And is the vaccine useful to persons who have positive tests for COVID? And does the vaccinated person need to wear a mask and observe social distancing still after vaccination?
The first part, so far, the information is accumulating that the current vaccine is effective to a certain high degree, not completely, against the variants. And there is ongoing studies about whether make a booster dose or a modified vaccine, and this can be done quickly because the principle is already in place in the lab. The second part is
the vaccine useful to people who have been positive for COVID already? Who had COVID and then they got vaccinated?
Yes. The immunity that happens from the disease or from the vaccine varies from one individual to the other. And in general, we know that these two vaccines available now is 95% effective. We don't know the level of immunity in anyone. Therefore, the person has to still have the mask and the social distancing. And the person who got the disease we recommend that he takes the vaccine also to supplement or complementing the immunity.
Great. Another question for you, Dr. Vanchiere, under the same rubric here. How does the person know if he's infected or she's infected with the original virus or with a new variant? Is there any difference between both?
Yeah, so there's a lot of questions and worries about the variants that we're seeing. We have been tracking, our lab and others around the world have been tracking now since the beginning of the pandemic, the slow evolution of COVID virus, COVID-19. And the general rate that it mutates at or acquires mutations is about 2 mutations every month. So what that tells us is now we're a year in, that if you compare the virus we're seeing now to the virus that started this pandemic, that there are about 20 to 25 changes in the virus. Most of them are trivial, have no effect on the virus function or on the pathogenicity or transmissibility. They're just accumulated changes that allow us to see and understand virus transmission. So they're useful for us as a signal of evolution of the virus. The variants that we're seeing now emerging in different parts of the world are apparently more transmissible. That is, a lower amount of virus is required to transmit it to another person. However, they are not more potent or more pathogenic or stronger viruses. They're all at the same level of causing severe and critical disease, okay? So we're not looking at worse viruses. They're just a little more easily spread from person to person because of these variants. So understanding that takes a lot of laboratory-based scientific work, and so that's going on in a lot of places. We'll know more in the next several months as they can be characterized further.
Thank you. So we don't really know at this point if you get this variant or that variant of the vaccine just clinically or from the symptoms that you have after acquiring the virus.
That's right. And at this point, whether you have a variant or a non-variant doesn't matter. Really it's not of clinical importance. It's only a public health epidemiology question.
One more question under this topic to Dr. Bahna, and this is a question that is really probably would have been under the fertility and pregnancy-related topic. Does the vaccine have the potential to change a person's DNA or RNA or make any change to their genetic makeup? So people are concerned that that could be transmissible to their offsprings and their children and grandchildren.
Great. I'm glad that this question is asked because the spike protein or any fraction of that, any modification of it, does not enter the nucleus of the human cell, where the nucleoprotein, the genetic material is there. So it is completely protected.
So when my children asked me about that, I explained to them that the cell is like an egg. When you crack an egg to fry an egg, you have the yolk and the white. And I told them that basically the spike protein in the virus stays out in the egg white. It doesn't go into the yolk of the cell where the genetic material is. So we think that, cells are tiny, but even with that picture, the virus is not getting close to our genetic material, and neither is the vaccine.
All right, I'm going to move on to a different topic here because we still have only 4 or 5 minutes, and I'm going to try, for the sake of time, address some other questions of importance here. Questions related to the treatment of COVID. So the first is a question I'm going to ask you, Dr. Vanchiere, to address. Would taking prednisone after testing positive prevent the disease? And what is the treatment for a person with just mild symptoms? So one question about steroids, another question about just what do we treat of very mild symptoms? And what is the treatment of the new type of infection of multiple systems in children, or the MSC, that we've been seeing lately?
Yeah. So currently, the recommendations for treatment in mild cases of COVID are only supportive care. That is fluids, Tylenol, ibuprofen, and general care that you would take for flu or cold or cough or whatever it might be. Steroids are reserved for use in patients as directed by their doctor, and usually those are patients at higher risk, especially patients in the hospital. And the problem with taking steroids early in infection is that may actually blunt your immune response. And that's really Dr. Bahna's expertise and it also depends on the amount of steroids you take. So at this point, just a positive test is not an indication to get steroids, and steroids are not without their own complications. So
I agree, and let me simplify it more. Steroids, in general, are anti-inflammatory. We use them for many diseases for that purpose, as well as immunosuppressants, and they're also used in certain diseases for that purpose. At the beginning of the battle between the virus and the body, the immune system is fighting. I don't want steroids at this stage so that I don't suppress the immune system at that time. And the vast majority, as Dr. Vanchiere mentioned earlier, that the people will be asymptomatic because our healthy immune system overcome the problem, won the battle. Later on, when the immune system becomes sort of defeated and trying to fight very hard, a lot of casualties happen inside from the cytokines or the mediators or chemicals produced, which is called cytokine storm. Here, when we need, hey, kids, stop. And we need a good dose of the steroid, particularly the dexamethasone, at that severe situation.
And so the third question you asked, Dr. Mhanna, is about the syndrome of multisystem inflammatory disease in children. This is a complication of COVID infection that occurs usually within a few weeks or a month or 6 weeks after the child has recovered from COVID. Some of those children have had no symptoms of COVID. They didn't know they had COVID, but then they develop a syndrome where the immune system is turned on very non-specifically. We don't find the germ in their body. There's not COVID there detectable in these patients any longer, but something about their immune response has turned on an abnormal inflammatory response that can affect the heart, the lungs, the liver, the kidneys, and even the brain. And we we still need to know a lot more about this syndrome. It looks like a syndrome of inflammation that we have known about for more than 50 years called Kawasaki syndrome. And we now know, because of the similarities in those two, that we can use the same strategies that we use to treat Kawasaki syndrome to treat this multi-system inflammatory disorder. Kawasaki is an uncommon disease. We may see here in the Shreveport area 5 to 6 cases a year at most, typically. The inflammatory syndrome with COVID that we're seeing in children, we've now seen between Dr. Bocchini and myself, the two infectious disease doctors for kids in this area, we've seen about 20 cases just in Northwest Louisiana. So this is a lot more common than Kawasaki disease, and the CDC's statistical analysis there suggests that about 1 in 1,000 to 1 in 5,000 children who get COVID infection develop this multi-system inflammatory syndrome. But we still don't know exactly why those children and not others. We do know that it is more prevalent among African American children and Hispanic children, but again, we don't understand the reason for that at this time.
I know that there are so many questions left to answer, but because of the time restraint, I'm going to just have one question that lumps actually 2 or 3 together in one. It's under actually a theme by itself. I'm on medications for asthma and blood pressure. Do I need to stop any of these medications? Another one in the same, I'm a 55-year-old diabetic. Would the vaccine help me or messes up my blood sugar? And the third one was, my dad is 85 years old and who has a triple bypass and other conditions, who's never been vaccinated before except for the flu. Would he have any side effects getting vaccinated?
In fact, these conditions are good recommendations for getting the vaccine. Some of these conditions are autoimmune phenomenon where the immune system is already weakened or have secondary immune deficiency. The vaccine will not be 100% like the other healthy people in efficacy, but it will be useful and needed. The medications that are mentioned should be taken to control the comorbid or the underlying other diseases. And there are many biologic agents now are known to suppress the immune system because the condition, the disease requires that. Still, patients will need to take the vaccine and benefit to any degree from it.
With that, I want to thank both Dr. Vanchiere and Dr. Bahna for their expertise and their beautiful presentations and answers to the questions. We will try to address many of the other questions electronically. If you send us your email, either Dr. Bahna or Dr. Vanchiere or to me, we can reply back to you with a written answer. Thank you for the attendance and thank you for the opportunity to give you this update.